After a lifetime of covering social change as a journalist, I am now talking to all of you about making social change. I remember many years ago overhearing my daughter having a conversation with a friend. And the friend said to her, "What does your mother do?" And I heard my daughter said to her, "Well, my mother is a columnist." And there was this kind of silence in the other room while her friend was trying to figure out what on earth that meant. And then she said, "What's that?" And Katie thought for a while, and finally she said, "Well, my mother gets paid for telling people what she thinks." So telling people what she thinks sounded like a good title for a course. I was invited to Stanford to give a course on column writing, on opinion writing, and I decided to name it Telling People What You Think. So I arrived on the campus at Stanford, and I opened up the registration book, and I saw that they had said, "Ellen Goodman is here, she is a visiting professor, and she will be teaching a course called Telling People What to Think." So this was most certainly not what I do. So I went down to the registrar's office, and I explained to her, and she was extremely apologetic. And she said, "No problem, I'll send out a campus-wide email and correcting it," and which she did immediately. And she sent out a campus-wide email saying, "Ellen Goodman is here. She's a visiting professor, and she will be teaching a course called Telling People How They Think." So I actually went from being a fascist to a neurologist in very short order. And that brief stint of neurology is, I assure you, the only medical qualification I have for my work now as a founder of the Conversation Project. The Conversation Project is asking us to engage in the most important conversation Americans aren't having. We are asking for an audacious change to see that everyone's wishes for end-of-life care are both expressed and respected, and that more of the people that we love will die in the way that they would choose. Now, I suspect that many of you have come here with a certain measure of uncertainty about how and even whether you can talk to the people you love about dying. For many of us, just talking about the D word feels suspiciously and superstitiously like letting death into the room. But I hope that you will leave this afternoon committed to being agents of change and champions of a change in the way we live at the end of our lives that will help us transform this community. First, let me remind you just how much change we have already been through because we don't always recognize it. I mean, my mother regarded doctors as Dr. God, delivering a diagnosis from the mount like an infallible doctrine, and delivering prescriptions as if they were tablets. My generation is more likely to regard doctors as partners, perhaps even junior partners, in healthcare. It's been over 40 years since the publication of the most important healthcare manual of my generation of women, Our Bodies, Ourselves. And this was a really seminal book that told women who knew, after all, astonishingly little about how our own bodies worked to take ownership of that information. And in some ways, that book was the beginning of what we think of now as people-centered medicine. Today, people are getting information, misinformation, and disinformation from an extraordinary number of places. Before they see a healthcare provider, they have already seen Dr. Google and probably Dr. Oz. They may have had medicine pitched to them on television ads with that inevitable disclaimer, "Ask your doctor." The evening news is punctuated by COPD ads and by ads for Cialis, which promise that you can have sex in a hot air balloon or in 2 bathtubs. I haven't figured out how they do that yet. People may also come into the healthcare system with a diagnosis from a blog and a prognosis from a medicine show. There is a message. They've chatted about their symptoms on Facebook and joined a Twitter group. There is a message that medicine has to become more person and family centered. We are living in an era when healthcare providers no longer control, they have to engage. Let me just say that this evolving world puts a much stronger priority on conversations with patients/people. The second and related change is about demography. Need I remind you that the baby boomer generation has been the primary change agents of our own culture. We led the civil rights movement, we led the women's rights movement, we led the gay rights movement. We are the pro-change generation. And now, willy-nilly, ready or not, we are embarked on another huge social change, the longevity revolution. In the last century, the average United States lifespan has grown by 30 years. In 1900, the typical American lived to be 47, and today the typical American lives to be 78 or over 80 for women. There are about 60 million Americans over 55 today, and in another quarter century, there will be over 100 million. And every day, another 10,000 baby boomers turn 65 and tells us all about it. We know about this in terms of numbers, arithmetic, but Americans haven't really absorbed this emotionally or personally. We are told that 50 is the new 40, but we aren't told that 60 is the new caregiver of the 85-year-old and 70 is the new caregiver of the 95-year-old. That famous sandwich generation has in fact become the club sandwich generation. We also are told that we have a generation of aging people who are poised to overwhelm the healthcare system. But we also have this generation of people who were encouraged to lead examined lives, who are now poised to do something quite new, examine how we want to live, how we want to be listened to, as well as to listen all the way through our lifespan to the very end. Technology has led to modern medical miracles and that ability to prolong life, which we all applaud. But it has also made it much more likely that death will not be what we used to think of as natural. It's made clear that many of us will face a cascading and confusing number of medical decisions as we or our loved ones come toward the end. The healthcare improvements that have led us to the longevity revolution have also led us to this tipping point, to the moment when we truly need to face the one difficult and crucial conversation which we have avoided for far too long, the conversations about how we want to live at the end of our lives. If there is a condition that everyone in this room, indeed everyone in this wide, contentious, and diverse world shares, it is our mortality. There is no margin of error for this survey. Indeed, my favorite line about this came from a headline in The Onion, the online satirical magazine, which said, "Death rate holds steady at 100%. We are all mortal, and yet, as you all know, we have been immeasurably slow in recognizing and acknowledging how many of the people we love are not dying in the way that they would choose. If we do everything to improve healthcare and do nothing to improve the way people are dying for them and their survivors, we will have failed. So if we are to tackle a problem that will literally affect everyone, and if we want to transform something as huge as healthcare, let's think big. We need to change the way the people we love are dying. This is the belief that's at the heart of the work of the Conversation Project, a public engagement campaign to help change the cultural norm from not talking about our wishes to talking about them, to making this a normal part of the adult checklist of responsibilities. 2 years ago, we did a national survey that said that 90% of Americans think it's important to have the conversation. That figure is fairly startling because 90% of Americans do not agree on anything, including the national anthem. But only 30% of them have actually had the conversation. Most of them defended their reticence by saying they thought it was too soon. But at the Conversation Project, we always say it's always too soon until it's too late. So the good news is that the importance is finally breaking through. The bad news is that there is still this reticence, this tongue-tied hesitancy in knowing how to begin. We need to close that gap between the 90 and the 30. Most of the social changes that we have all lived through have come about because people began to tell their true stories. I have found that when people ask me what I'm doing now and I say I'm involved in encouraging end-of-life conversations, there is like a half a beat and then out pours a story. It's incredible. A story that has so often been kept under wraps for so long and yet is so close to the surface that all we need is a little cue, a permission, a tip, and it comes pouring out. This is very parallel to my experience with the women's movement all those years ago when everyone began. Everybody had a story of sex discrimination, harassment, inequality, anything. But it wasn't until those stories began to be shared that change started to happen. So I began my involvement with the Conversation Project because of my own story. Around the time I turned 60, I went from being a working mother to being a working daughter. I'm sure that many of you know exactly what I mean. My mom began a long, slow decline. I was what a woman who was on the same visiting schedule with me at her assisted living called the designated daughter. As my mother went into her 90s and was no longer able to decide what she wanted for lunch, let alone what she wanted for health care, it fell to me, to my shock, to be making all kinds of decisions. I was making decisions for which I felt, I assure you, wholly unqualified and unprepared, indeed blindsided. My mother and I could talk about everything. I once described her in an article I wrote as a woman who would listen to my problems until I was bored with them. But the longest conversation we had ever had about end-of-life care was when she would see somebody in a bad shape and she'd say, if I'm ever like that, pull the plug. But of course, when the time came, there was no plug to pull. There rarely is. When my mother died, I began to do what women do. I began to talk with others. We started to share stories of our loved ones, the good deaths and the hard deaths. I found out that no, I was hardly alone. And soon a group of us, caregivers, clergy, media, and people we began to meet. At that first meeting, we each took off our professional hats and told our stories. Then we asked each other, surely there's got to be a way to make this easier. How could our loved ones live at the end of their lives in ways they would want? How could their survivors, and in time our own survivors, be left with less guilt, uncertainty, depression about whether we had done the right thing? In surveys, 70% of people say they want to die at home, surrounded by loved ones, but as many as 70% actually die in hospitals and nursing homes. Home is not just a physical place, it's an idea, a way in which we want to live our lives, we want to end our lives, in comfort with people we love, not in an ICU. I have never heard anybody say that what they want to do is die in an ICU. We began to realize that the difference between this good death and this hard death often pivoted on whether people had expressed their wishes and whether those wishes had been respected, first by family or friends, and then by the healthcare system. For the most part, Americans assume that such conversations take place between patients and care providers, but doctors are often uncomfortable and very often untrained in initiating these talks. In Massachusetts, for example, only 17% of people have spoken to their doctors about their end-of-life wishes, and in California, only 7% of people have talked to their doctors about their end-of-life wishes, which is exactly nobody. Nevertheless, we are at this huge tipping point. We began the Conversation Project when, you may remember, death panels were in the air. The idea that a doctor would talk to a patient and get paid for talking rather than for doing a procedure was labeled by politicians, Sarah Palin in particular, as death panels. And the politicians mostly dove under the table. Now, less than a month from now, Medicare will finally begin paying doctors and providers for having these conversations. And this rule changed this fall with virtually no controversy. This is a huge example of cultural change because it never would have happened if there weren't that real feeling that the culture was changing. Let me describe our role at the conversation as a piece of that change. When we began to form the Conversation Project, we went to the Institute for Healthcare Improvement, and they helped us call together experts laboring in this field for decades. They had been trying to push the boulder up the hill. They had been trying to change from the inside of the healthcare system. And what they told us was that nothing was going to change until we went outside the healthcare system and got people talking about this around the kitchen table. And that fit our own experience. So we believe the starting point really is that proverbial kitchen table with the people we love and who may be making decisions for us when the time comes. The truth is that we still engage in a sort of conspiracy of silence and denial around these issues. Elderly parents are often reluctant to worry their adult children. Those children, in turn, are reluctant to bring up dying with their elderly parents. We attempt to protect each other and protect ourselves from the reality of our mortality, and in that mutual protection racket, we often end up alone and leave our survivors bereft. There is often the same kind of denial between doctors, providers, and patients. Few doctors actually have these conversations, and yet many of them truly want to. And they also suffer from the same lack of communication. Doctors themselves, by the way, are much more likely to have refused aggressive care and signed advance directives for themselves than for their patients. In a California study, nearly 1 in 5 patients in a hospital's intensive care unit got treatment judged by the physician in charge to be ineffective, needlessly aggressive, or pointless, given the patient's dire state. This wasn't malicious. It was a vast disconnect, a kind of terminal miscommunication. So I'm hoping that everyone here will be a part of a movement to break through the conspiracy of denial and to change the cultural norm beginning in your own community. The Medicare changes are not enough. They are very modest. But what we need is to go beyond those rules. We need to train doctors and healthcare providers so they are comfortable talking about the end of life with their patients, and we need to talk to each other. If there was one thing we know, it's that the longevity revolution has brought with it a set of twin fears. People approach the medical system with conflicting fears. The fear on the one hand that we will not get the health care that we need, and the fear on the other hand that we will get more aggressive care than we would want. If we can put people's wishes and people's voices, if we can put people at the center, promise that they will be heard, we can reduce both of those fears. And by the way, rebuild trust in the medical system. One of the remarkable things for the Conversation Project is that since we launched, nearly 300,000 people have come to our website. 80% of them, that's just ours, we're in many other websites, 80% of them have downloaded our Conversation Starter Kit that promises to make it easier to talk to the people we love. This reminds me that people are ready but reluctant and extremely eager for help in the beginning. Our Conversation Starter Kit isn't scary or highly medical. It asks about your values, about how you want to live through the end of your life. It helps you think about what matters to you, not just what's the matter with you. There are, just give you a sample of some of the things in our kit. We ask, for example, what are the 3 most important things you want your friends, family, or doctors to understand about your wishes for end-of-life care? Who do you want to be involved in that care? Who do you want to make decisions for you if you cannot make them for yourselves? And half of all the people over 65 who go into a hospital are not able to make decisions for themselves. Do you worry you won't get enough care? Do you worry you'll get overly aggressive care? Would you prefer to be actively involved in the decisions about your care, or would you rather have doctors do what they think is best? And there's many more things there. One of the remarkable things to me is how quickly the media got it when we began to go out and tell our story. In fact, some of the most touching stories, including one done on NPR, were when a reporter has a conversation with her own parent. In one NPR story, reporter Carrie Goldberg reported, "I thought this was something I was doing for my dad, to get clear on his wishes. But in the process, I learned that he was doing it for me, that he wanted to make sure I came away from his ending without guilt, knowing that though he didn't want to die, he didn't fear it." So where are we now? We have added more tools, a kit on how to talk to your doctor, subtitled because he may not start talking to you, a kit on how for families of children with serious and terminal illness, and we are just finishing one now for families of people with Alzheimer's and dementia. And we are bringing the Conversation Project to people where they work, where they live, and where they pray. This is where we invite you to join us. We have relationships with about 300 different groups in 44 states. We don't run them. You're the ones who know your own community, but we can help share best practices, keep you in touch with others. We've been really impressed with all of the communities, starting with terrific activists and citizens all on their own. It's been amazing. We want people's wishes to be expressed and respected, so we see what I refer to as a kind of double helix of social change, if you will forgive my DNA. Change from the outside brings change to the inside. The healthcare system in turn changes and brings change to the outside. We need to express those wishes and be sure that the healthcare system respects them. We have as well a faith-based initiative that we piloted in Boston last month. We had some 35 congregations, we like to say from Baptists to Buddhists. Huge diversity, all at the same week-long period, the clergy shared. They did a teach and preach. They got their congregations to do this, the conversation starter kit. We also piloted a public health messaging campaign, kind of like an anti-smoking campaign, that we hope will get people to the kitchen table. You can see that online too. We can share all of these ideas with you. If our audacious idea were in a course catalog, a different one than the Stanford one, I would put it under humanities and not under economics. Our goal we do not have a dog in that fight. But we do know that a quarter of all medical care expenses go to the 5% of people in the last year of their life. We know that 1 in 10 elders has surgery in the last week of life. How much of that was futile? Or in fact, against the patient's wishes? Today, the debate about healthcare is very often framed in the language of cost cutting, rationing, less and less. It's framed as what the healthcare system will do to you. This is one area in which letting family and patients' choices drive the decisions could actually result in lower costs, financial, and much more importantly, emotional. We may, as I said, even be able to rebuild trust in the medical system. But more importantly, we can ensure a more humane death. This is a huge undertaking, I recognize that. It's a big cultural change, but we have made such cultural changes before. Remember when we could only whisper the word cancer? Now we can all talk about erectile dysfunction in public. Remember how the model of birth in America was transformed from the outside in. It was not doctors, I assure you, who said to families, please come in, bring the video camera, bring your husband into the opera, let's have the baby in a bathtub. It was not doctors who said this, I assure you. It was people who brought that change into the medical world, who said, you know what, birth is not just a medical experience. It's a human experience. And now we are saying dying is not just a medical experience. It's a human experience. So if the last generation transformed the way we give birth, we can transform the way we die. Finally, I want to tell you one last story. At the end of one of our meetings, Karen Boudreau, who is now a chief medical officer at the Boston Medical Center's healthcare plan, wrote a letter to her children. She just scribbled it off at the table. In part, this letter said, don't panic. It's okay. I'll try to let you know what I would want. And it ends, if you're faced with a snap decision, don't panic. Choose comfort. Choose home. Choose less intervention. Choose to be together at my side, holding my hand, singing, laughing, loving, celebrating, and carrying on. I will keep loving you and watching and being proud of you. So we begin with the question asking people everywhere, have you had the conversation? And we hope that beginning right here in this community, we can ensure that the resounding answer will be yes. Thank you.
So we do have staff going around. If you have a question that you'd like to write down, please hold it up and we'll try to get to as many of them as possible. So the first question, Ellen, is what is the project doing about educating and training doctors about the conversation and educating them about the ethics of allowing the functioning of those who don't want intervention?
The Conversation Project is working with another group at IHI, who our parent company called Conversation Ready. They've been working mostly inside the healthcare system. We've been working mostly in the cultural space. And together, the conversation-ready people in particular have been engaging with hospitals to figure out the best way to make sure that everybody's wishes are respected. One piece of that, obviously, is that doctors need some comfort and training in having these conversations. So IHI has on their website, they have an open school course helping doctors and students to plan these conversations, and there are a number of groups in their hospital collaborative who are also working to to train the doctors there. We think that the first thing that needs to be done in any hospital setting is for everybody in the healthcare setting to have the conversation. And I mean everybody, from the kitchen help to the chief of neurosurgery. Nobody's going to be able to do it with their healthcare, with their patients or with their neighbors until they've done it themselves. So one of the things that we have done when we go places is we spread the tables with red and white check tablecloths, and we encourage the doctors who often, or healthcare providers who often think they're there as experts, the first thing, let's do it yourselves. Have you had it yourself? You'd be surprised how many have not, or more have not than confess. And have you had it with your family? Have you chosen someone to make decisions for you if you can't make them for yourself? So that's our first step. And the healthcare system, by making that a priority, everybody in a healthcare system is an expert to their neighbors, So that becomes a great wedge into the community, a great starting point into the community.
Can you share what you would have changed in your mother's dying experience?
I would have changed my comfort level, to be selfish about myself. I remember one day my mother had, towards the end, as people don't realize that dementia and, of course, Alzheimer's are terminal diseases. People just don't know that. They think it's kind of like a mental decline, but the rest of it, goes on forever. But one of the things often in dementia is that people get pneumonia and in Alzheimer's. But in any case, the question about my mother had several bouts of pneumonia, and I remember one day I was at my desk and I was on deadline, and I got a phone call, and the phone call came from her doctor and said, "Your mother has pneumonia again. Do you want us to treat her with an antibiotic?" And I thought, is he asking me whether I want my mother to live or die? Is that what's going on here? And could I have a minute? Could I call you back? At that point, I said, just to go ahead with the antibiotic. I don't know what she would have wanted about that. She died sometime later of congestive heart failure, but not very much later, because, of course, it starts recurring. You're on that end slope. But I didn't know, and I think the main thing is to have heard my mother's voice in my ear as I had to make these decisions. And several times I did stop procedures that had no value that I could see. And I'm a trained reporter, so I know how to ask the next 3 questions, So I could see had no value to her as she was then. But it was hard, and I'm sure a lot of you have had similar experiences. A lot of people who have, chemo in the last week of their life, because nobody can quite say it's not going to do any good. So there's this relationship between getting the truth, getting real facts, and making decisions that goes on that's hard too.
Are religious institutions helping or hindering the conversation?
So I think in general, one of the things that we know is that there are huge differences in various ethnic groups, although everybody finds dying hard, And religious leaders, clergy, often have a very strong spiritual role when people are in trouble. Yet they also are not trained to have these conversations. So they also can feel frightened, tense or stressed out when they're called on to have this. And so if they can lead people into having them with their families first, that makes life very easy. There are some differences in ethnic and religious beliefs, differences in the afterlife, but we had one conversation with a woman who's actually both a doctor and an AME minister, and she said, everybody in my church wants to go to heaven, but nobody wants to die to get there. And which I thought was quite charming and true. And she and her husband have led one of our one of our most robust faith-based projects. So we found that virtually all of the very diverse groups, I mean, it's Boston, it's a big city, I mean, there's every religion you can imagine. We found that they all found the Conversation Starter Kit quite useful to them to open up these conversations with their parishioners.
So in Maryland, we're having a conversation right now about death with dignity and legislation related to that. So has the Conversation Project created a legislative agenda? Is there a role for state legislatures to both require end-of-life wishes and to adopt death with dignity laws? Can you talk about the Conversation Project and your feelings?
Sure. Well, the Conversation Project is agnostic on aid in dying. I'm on the record as being in favor of it, but I think we have to always, there's a real possibility that that legislation can hijack the whole conversation. Let's be serious about what actually happens. In Oregon, which has had legal aid in dying for 10 years, what is it? 7, thank you very much. We've got a little expertise, I appreciate that. Only 1 in every 500 people who dies chooses assisted aid in dying. So, to me, politically, why are we getting into this knockdown, drag-out, divisive fight over something that will help one, and not that, and we still have to concentrate on the 499. Now, as I said, I am personally in favor of those extreme cases, but I don't think it's really going to change the way people die in America. I don't think it's going to really bring comfort to the 499. So that's just both a personal and a Conversation Project view. Would I vote for it? Yes. Do I think we should put a whole lot of energy into it? With all due respect, I don't think it's the way to really make a huge social change.
Are hospital staff required to honor a patient's advance directive?
I'm not sure about the legality of that. You may be more sure about that than I am, but we are doing some research. One of the things that we know is that we talk a lot about medical mistakes, and which is a harsh term too. But what we want this to be one of the ways in which you check whether somebody has gotten appropriate care. For example, when you go into the hospital, you have to check whether somebody's allergic to penicillin, just as an example. And on that list of things, you should have to check whether that person has an advanced care, has a decision maker. I don't use the word healthcare proxy because I'm sure if you ran a survey, there would be 4% of the people would know outside of the healthcare system would know what healthcare proxy means. I use decision maker. That's just, but you know what I'm talking about. So there should be these, and we should also be doing interviews at the end of, with families after death to see whether they feel their loved ones' wishes were expressed and respected. So this should be charted. So this should be one of the things that are qualified as good health care.
So I know that Mike Davis would say that the advance directive is a legal document and should be followed by healthcare
Is that
practitioners.
state by state, or is it?
Mike, would you like to address that? And I do want to acknowledge the work that Howard County General is doing in this area as well, and Mike as part of the Ethics Committee.
Thank you. Just briefly, I think as the advance directive embodies the wishes of the patient, that to the degree that the care violates the wishes of the patient, I think there is potential liability. Obviously, there's always a gray area. There's lots of discussion of what those wishes might be. But I think if you've got somebody who's speaking strongly on behalf of the patient based on actual knowledge, and that's what we're trying to do, is always have the conversation so we know what that answer is. I think that if they, because the whole concept of the advance directive is based on care, and can a doctor provide care to a person? Can a doctor touch a person without that person's consent, without informed consent? And if that informed consent is not given, or if it's done in violation of the wishes of the agent, I personally think there is liability at that point. Case law on that is weak, so I have to say that.
I think it's up for grabs, and because I've heard so many stories. It may be different from one state to another. I've heard so many stories of people where the family's reluctance to follow the advance directive of the patient, and the doctors went with the family out of fear of being sued in the other direction. I think you're right. I think the possibility of litigation on either side is there, but all the more reason why these conversations should be earlier. I mean, for example, say one of the projects that we're doing is, say somebody comes in to your practice, and you hand them the conversation starter kit or an advance directive or whatever, and say, bring this back next time. And you have a decision at no more than 3 visits before you get that information or whatever. I'm making it up. But there has to be. And when somebody comes into the ER, instead of saying, who's your next of kin, who's your healthcare decision maker? Because you may not choose your spouse, child, whatever, but that should be part of the routine. Well, good care for Alzheimer's patients does not include a ventilator or a feeding tube or any of those things. But the mental status, the question of dementia in general, is one of the trickiest ones, and it is also one of the reasons why it's interesting, because aid in dying, of course, does not cover anybody with dementia. And yet, when you ask people what they're most afraid of, it's dementia, right? So it's another reason why it's not that helpful. But one of the trickiest things, and I've been through this because my sister died of Alzheimer's almost 3 years ago, just 3 years ago. But it's a really tricky thing. On the one hand, people really may state their wishes beforehand, and on the other hand, somebody with dementia may become a different person. And I don't know how ethically we struggle through it. I do know how at the very end you could, but in that middle zone, there are a lot of people who are writing and thinking, and it's really an ethicist nightmare. So we've had this. The question was about siblings who disagree, and my best friend's eldest daughter, after she found out the work that I was doing, said to me, "Oh my God, we better have this conversation, because I can see me and my sisters, fighting over my mother's comatose body," which is a rather direct way of putting it. But a doctor in Virginia said to me, "You know what my biggest problem is as a physician? My biggest problem is what I call the seagull syndrome." Has anybody heard of this? The seagull syndrome. And I said, "What's the seagull syndrome?" And he said, "It's the child who's been least involved, who flies in from the West Coast and dumps all over the plan." Only he didn't say dumps. And so one of the real primary reasons to have these conversations early is that your legacy isn't families breaking apart. Because it's not what your son and your daughter wanted. It's not who loved mom more or who mom loved more. It's what mom or dad or whatever wanted. And getting that voice in the room, even as we're doing our Alzheimer's kit, one of the things that we are suggesting to people when you can no longer hear, when you can no longer trust the person with dementia, is to the degree that you can, bring that person that you know into the room for these conversations.